Services, Punjab, a special presentation on keratoconus. And we feel honored to have with us an eminent ophthalmologist and a corneal doctor and a corneal surgeon, Dr. Ashok Sharma, with us. Dr. Ashok Sharma is a former associate professor of PGIMER Chandigarh. He is a corneal fellow of LVPEI Institute, Hyderabad, and he did it in 1994. He was an eye consultant in Maryland, US, has published about 104 research papers in the peer-reviewed national and international journals. He has been awarded by American Academy AAO Achievement Award 2009, International Ophthalmologist Education Award 2013, International Scholar Award 2013, and Best Poster Pediatric Corneal Transplant in 2015. So Best Paper SSI Conference for FIBRIN glue, this was in 1998, and a Best Paper for Dry Eye in GRA at National Conference 2000, and another Best Paper on Chemical Eye Injury by WHO SAARC Conference in Nepal in 1998. And he also got Himachal Pradesh State Award for Contribution in Surgery 2009 and a Cornea Hero Award by our organization Sipher in Chandigarh in 2020. So, sir, we welcome you.
Thank you, Dr. Rakesh Gupta, President Sipher and former Director Health Services, Punjab. I shall be talking about a common corneal problem known as keratoconus. Keratoconus, as we understand, is a progressive disease. And in this disease, the cornea thins down. Normally, cornea is a spherical structure, just like a convex lens, basically. So if the cornea becomes thin, it starts bulging outwards and the corneal power becomes irregular. So because of all these reasons, the cornea loses its focusing power and the patient is not able to see clearly. In early stages, he may use glasses with this difficulty, but most of the times they need contact lenses. But if the disease progresses further, even the contact lens do not work. There are some other diseases which have similar appearance clinically, but they are totally different. One is megalocornea, in which the corneal diameter is more and corneal size is more, but the corneal thickness remains normal. Then there is a condition known as keratoglobus, pellucid marginal degeneration, terine marginal degeneration. In both these degenerations, there is a thinning, which is usually in the periphery of the cornea. Coming to the incidence of the disease, this disease is quite common, and this occurs almost 1 in 3,000 of general population. And in Asians and Indians, compared to Caucasians, the incidence is at least 4 times higher. So we have much higher incidence of this disease in our country. And also in our country, as well as in other Asian countries, the disease present in very young children. So all those children, all those patients who present to us with this disease in this region are younger than in other countries. Now coming to the diagnosis, that how to diagnose this disease. For common man, if a patient is not happy or person is not happy with glasses, he is changing his glasses frequently and not happy with any of the glasses, he should come for the screening. And it's a possibility that he may be suffering from keratoconus, because in keratoconus, the pair of glasses usually a patient doesn't satisfy the patient. But as far as we as ophthalmologists are concerned, we examine our patients on slit lamp. We call it slit lamp biomicroscopy, and there are several findings which suggest that this patient may be having keratoconus. Like there is either central or inferior corneal thinning. This is very characteristic of keratoconus disease. Then Fleischer's ring. This is basically iron deposition just as at the base of the cone. So this you can see, and this is more clearly visible in cobalt blue filter. If you see there is an arrow and you are seeing a line there, this is known as Fleischer's ring. And then Vogt stria, these are like stress lines, vertical stress lines in stroma, and they are also these lines also indicate that the patient is suffering from keratoconus. Now, when the disease become more advanced, thus there are certain other signs which appear, like Munson sign. Munson sign is a sign when the keratoconus is more advanced, and if we ask the patient to look down, we get this kind of triangular appearance of the eyelid rather than the round appearance which we usually get. And if we project the light from the temporal side, on the nasal side, we see this kind of light reflex known as Rigiuti sign. And if we throw the light into the eye after pupil dilatation, we get this kind of oil droplet reflex as we are seeing in the lower left picture. So all these signs, they indicate that the disease is now advanced, and these patients, they may not be amenable to other treatment options than corneal transplant surgery. There are several other tests which we can do to diagnose. If we do the retinoscopy, there is a scissors movement of the reflex. Like if the outer reflex moves down, inner reflex will move up. And if the outer reflex moves up, the inner reflex will move down. So this is known as the scissoring of the reflex. And then on keratometer, the corneal Myers are not regular. Like they will be distorted Myers, and they will not be round, and they may have the apex like in this diagram towards down. So there is a crowding of the Myers because of the keratoconus. And more recently, we have more advanced test, which is known as corneal topography. In corneal topography, what we do is we image the cornea, and then we subject it to the like computerized evaluation, and we get so much information that we diagnose the keratoconus. Like in this patient, we have this is basically the front surface of the cornea. And normally in the cornea, in the central part, the power is something like 42, 41, or 43, not beyond that. And if it is more than 47, it's almost indicative of keratoconus. Now, in this patient, if you look at one point in the center, we have power 42.5. The other power is 42.1. But then the two other powers are like one is 46 and the other one is 49. So this is classical keratoconus. You can see the inferior red area, which means that there is inferior corneal thinning and also the bulging of the cornea. And there are so many indices in this evaluation. And one of the most important means like the average K, which are 42.7 and 46.0. Then Kmax K is another indicator, which is 50.3, which is quite high and indicates keratoconus. Another finding in keratoconus is corneal thinning. So we are seeing that at the thinnest point, the corneal thickness is 477 micron in this patient, which is suggestive of keratoconus. Now, this is the information which we get about the back surface. And in a common language, we will say that the area which is red is showing that the points in this area, they are shifted anteriorly. So like there is a reading 60. So 60 means that this point is 60 micron shifted anteriorly compared to where it should have been in a normal cornea. So all these things, they indicate that the cornea is thin and ectatic, and the diagnosis of the keratoconus is confirmed. There is another investigation which can be done to confirm keratoconus, that is anterior segment OCT. This picture is showing the same profile, that in the inferior cornea there is thinning, because this is basically the thickness profile. But these days we have advanced anterior segment OCTs, which gives us the corneal epithelial mapping also, which is also useful in making early diagnosis of keratoconus. As we discussed in the early part only, that this disease is basically a progressive disease. So we should know that when we say that the disease is progressing. Now, if there is more than one diopter change in maximum keratometry, that is the Kmax reading I showed you in the previous patient, that was 50. So if there is a change of equal to or more than 1 diopter, so that means that the disease has progressed. Again, that if there is a myopic shift of more than 0.5 diopters or an increase in cylinder power of equal to or more than 1 diopter in 12 months, this also indicates that the disease has progressed. Unexplained loss of best corrected visual acuity is also an indication that there may be a progression of the keratoconus. Young adult who presents with 2 diopters of cylinder and 20/30 uncorrected visual acuity, while claiming to have been able to see just fine without glasses in the past, most likely the keratoconus has progressed. Now, what happens is that if the patient has a cylindrical error, like suppose of 2 diopters, so this patient has normal cornea, so this patient will see very well only if we give him 2 diopters of cylinder. Now, if the patient develops keratoconus, or if he has already mild keratoconus which progresses in the early stages, then he will be able to see without using this cylinder. So this patient may feel that I have improved, but this is not that patient has improved. This is that the disease has progressed and he is seeing without cylinder because of the multifocality of the corneal surface. So this should alarm the ophthalmologist that there is something wrong with the cornea and he should screen for the keratoconus. These are the same parameters which we discussed in a tabular form, showing that there is a progression. These are the various values which we note down for that. This is more advanced classification system for identifying the progression of the disease, also known as popularly Balance ABCD classification system. It takes into account the 4 different parameters, and these parameters are radius of curvature and then posterior radius of curvature, minimum corneal thickness, and best spectacle correction. So after taking all these parameters into account, we get the classification of the keratoconus, which can be used clinically and also to determine the treatment modality. Now, coming to the treatment or the management of keratoconus, we have 2 points or to manage. One is we have to arrest the progression of the disease. The second thing is that if the patient is not seeing well with the glasses, we have to rehabilitate the patient visually so that he is able to see clearly and perform his day-to-day activities or his professional vocational activities efficiently. Coming to the arrest of progression of the disease, we perform a surgery for this, which is popularly known as collagen cross linking with riboflavin. In Western countries, it is in short written as CXL, and in our country, most of the times we write it as a C3R. Now, this surgery was introduced by Professor Theo Seller, who was a mathematician and a physicist, and also an ophthalmologist. Now, this treatment struck him when he was advised cross-linking of his tooth filling. Once he was advised, he thought that the same thing can be applied even to harden the cornea so that we can arrest the progression of the disease. And the cross-linking has also been used to harden the arterial grafts or to harden the joint cartilages. There are several other indications also of collagen cross-linking in addition to keratoconus, and these include pellucid marginal degeneration, post-LASIK ectasia, corneal melting, and infectious keratitis. So in all these conditions also we perform collagen cross-linking. In collagen cross-linking, basically, what the basis behind performing this procedure is that the activation of riboflavin is done into triplet stage, and release of singlet oxygen and superoxide anions is being done. Ionization of amino groups like histidine, hydroxyproline, hydroxylysine, tyrosine, and threonine amino acid residues is done. And cross-linking, collagen becomes stronger and it becomes water insoluble. The dye which is used is, there can be various dyes in the market available, and there is various companies which market these dyes, but the dye which we are using is Pashke, And there are several modification in the dyes that you can use for epi-off procedure. You can use for thin corneas. So there are several modifications, and for like post-LASIK ectasia, you have different dyes. So the different dyes are available. But before performing UV exposure, you have to saturate cornea by instilling drops of riboflavin. And we have two options of doing the procedure. Either we do epi-off procedure or we do epi-on procedure. Epi-off procedure, we remove the epithelium and then we put the riboflavin drops, one drop every 2 minutes for 20 minutes. If we are using epi-on method, then we break the epithelial barrier by using benzalkonium chloride or paracaine, frequently putting, so that the dye permeate into the stroma. But epi-off procedure, although is painful and takes more time for healing, but is more effective also. So how we do this procedure? It's basically we remove the central 8 to 10 millimeters of corneal epithelium, and then we apply the riboflavin as we discussed earlier. And after that, the UV light is the cornea is exposed to UV light, and the standard Dresden protocol we used to use like 3 milliwatt per centimeter square for 30 minutes. So total fluence of 54 joules per centimeter square. But the issue is that if you increase the intensity of the light, then you can decrease the duration of the exposure. So on that basis, there have been several experiments, and finally it has come down that if you increase the fluence to 9 milliwatt per centimeter square and you use it for 10 minutes, this is equally effective. Now, this is epi-on procedure, what we were discussing, that you remove the epithelial barrier, not by removing epithelial, but by using the chemical agents like tetracaine or pilocarpine or benzalkonium chloride. And then you, after saturating it, then you can use the UV exposure. But as we discussed earlier, this is painless, but it is less effective also. Hypoosmolar CXL, that also we discussed in thin cornea. If the pachymetry is less than 400 microns, then we use the dye which is hypoosmolar. So this dye increases the corneal thickness, and we are able to perform the collagen cross-linking, and UV light does not reach the endothelial cells, because if it reaches endothelial cells, then the endothelial cells will be damaged and the patient is likely to get the corneal edema. Iontophoresis is another method of saturating the cornea which can be used. It is basically a non-invasive method in which very small amount of electric current is used, which facilitates the penetration of molecules of riboflavin into the corneal stromal tissue. We can also use the SMILE lenticule after epithelial debridement. We can place the SMILE lenticule over the cornea and then instill the riboflavin solution and perform the UV exposure. This will artificially increase the corneal thickness, and again is helpful if the corneal thickness is less than 400 micron. Another method which can be used for these corneas which has corneal thickness less than 400 micron is contact lens associated assisted collagen cross-linking. In this method, basically after removing the epithelium, after saturating the cornea with the riboflavin, we can put the soft contact lens which has thickness of 90 microns, and artificially we increase the corneal thickness so that we do not damage the corneal endothelium. So this method is also very popular, and we use sometimes when we have corneal thickness less than 400 micron. Now, this is accelerated CXL. This is what I pointed out earlier, that if you increase the intensity of exposure, like from 3 milliwatt per centimeter square to 9 milliwatts per centimeter square, then the duration can be decreased to 10 minutes. And this is also known as accelerated CXL. And this is particularly helpful if the patient is not able to cooperate for a longer period, And once this is giving equal results to the standard method, then we need not to go for the standard method. We can do the procedure in a shorter time. Rather than spending 30 minutes, we can perform this procedure in 10 minutes and after the saturation. And saturation also in earlier studies mentioned 30 minutes is now decreased to 20 minutes. So the total procedure can be reduced from 1 hour to 30 minutes. Pulse CXL is another method in which we like expose the cornea to UV light, and then we have a period for which there is no exposure. This provides more oxygen and also provide more effectivity. So this pulse CXL is more effective, and topography results also shows that we get better results if you use this technique. There is another term used as the customized CXL. In this technology, what we do is that we increase the treatment exposure to the weaker area, and this system comes inbuilt in the machine only. So this is again gives better results than the standard technology. This technology has unique offers, like it's programmable and customizable illumination patterns, integration with industry-leading topographer, and then real eye tracking. Just like in LASIK, we track the eye, that if the eye goes out of a certain range, it stops firing the laser. The same way in customized CXL, if the eye moves too far, it will stop the UV exposure. If we compare the keratoconus in adults versus children, the incidence of progression is much higher in children. Speed of progression is also much higher in children. Nearly 20% of keratoconus patients, they need corneal transplants, especially these children, they need transplants more often. And in general, it has been observed that in Asian patients, the corneal grafting is required more often and also at a younger age. These are various studies, and in children especially, because the progression is the risk is more and the progression is faster also. So the most of the times we go for the gold standard CXL, in which we expose the cornea for 30 minutes, or we go for AAO procedure, accelerated collagen cross-linking procedure. We do not perform AAO procedure in children. These are some of the examples. You can see that pre-op keratometry shows the disease is very advanced, more intense red areas, but after CXL you are seeing that the disease is less in both the eyes, right eye also and the left eye also. And we have done a study where we have seen that in children particularly, the procedure is effective, but if you follow up these children for a longer period, then some children, they can develop again the progression, and very rarely these children, they may require retreatment also. So we have seen that in 11 eyes there was progression, and in 53% of the eyes the disease was stable at the end of the 56 months follow-up. That means at 5 years. So after 4 or 5 years, because the collagen fibers, they change, and there is always turnover, and new collagen fibers, they come. So the treated fibers, they may have changed, and the disease may progress after 4 to 5 years after treatment in children. So we need to keep these children for under follow for longer period. There are certain contraindications to perform collagen cross-linking, and these contraindications include if the corneal thickness after removing the epithelium is less than 400 micron, or we have to perform the procedure with taking special precautions, which we discussed. Prior herpetic infection is a contraindication, because if we do treatment in these cases, there is a likelihood of reactivation of the viral disease. Concurrent infection, we have to control infection, then only we can do this procedure. Severe corneal scarring or opacification is again a contraindication. And if the patient has history of poor epithelial healing, again, we should not do this procedure because we will remove the epithelium and the patient's epithelial defect may not heal. Severe ocular surface disease and autoimmune disorders again are relative contraindications of performing this procedure. No procedure in medical science is free of complications. So is true with the collagen cross-linking with riboflavin. Temporary stromal edema or stromal haze that occurs in 100% of the patients, but that subsides within 2 to 3 weeks. There are only few patients, maybe up to 10%, where the high haze may be there for a longer period. And some of the patients may have the haze, which may remain there permanently, but it doesn't interfere usually with the vision of the patient. Corneal scarring, sterile infiltrates, these are some of the complications. Infective keratitis, which may be because of the poor eyelid hygiene or patient's habit of touching the eye frequently, or because of the contact lens that may occur. Diffuse lamellar keratitis has also been reported in patients whom we perform collagen cross-linking following LASIK procedure. We have a study where we reported way back in 2012 some patients who were treated outside and were referred to us for management. 10 patients. Now they have, the number has risen to 16. The 16 patients, they developed the persistent corneal edema. And this edema did not subside even after treatment. And we had to perform penetrating keratoplasty in some of these patients. And this the study we published in American Journal of Ophthalmology. There is a theory that we should protect the limbal stem cells during CXL. So we can have special kind of polymethyl methacrylate rings of different diameters. So if you can place these rings on limbus, they will protect. Or you can simply like cut the drape sheet, sterile drape sheet, and place it over the limbus after cutting it semicircularly. That also will avoid the exposure of the UV light onto the limbal stem cells and will prevent the limbal stem cell damage. Monitoring the progression of the keratoconus is very important, as we discussed in the early. So we need to perform the corneal topography repeatedly, maybe after 3 months, 4 months, or 6 months after surgery, so that we are able to know that the keratoconus is stable or it is progressing. Coming to the second point, that we have to make the patient visually comfortable. We have to rehabilitate the patient for vision. We have several options like spectacles, which work only in very early cases, then contact lenses, NTEX, topo-guided PRK, ICL, DALK. These are surgical interventions like deep anterior-lamellar keratoplasty and penetrating keratoplasty, DALK and PKP both. So these are all options available to us, and we have to choose the option depending upon the type of the patient. If the thickness of the cornea is reasonably good, maybe around 500 or more than 500, and the myopia or the minus error is mild to moderate only, then we can go for the combined correction of the myopia, plus we can do the strengthening also. So we have different procedures for forming the PRK plus CXL is the best one, because in this one we are not making flap and we are not making the cornea extra weaker. Only that much of the cornea is removed which is required to remove the refractive error. Whereas LASIK extra, yes, it can be performed if the thickness is very good and the keratoconus is very, very early. Femtosecond assisted LASIK we perform where the corneal flap thickness is 90 micron. So PRK had an advantage that we are not sacrificing even the 90 micron of the flap. Smile extra is again preferred. I would prefer Smile extra over LASIK because of that the biomechanical strength may be slightly more with the Smile. But it is not true if we believe that Smile, we don't get ectasia. We have a number of cases where the ectasia has occurred following Smile also. So there may be a little bit of difference in the biomechanical strength, but it doesn't prevent the ectasia. So we, in very selected cases where the corneal thickness is very good and number is very small, and it should be only spherical if we want to do the smile extra. Then coming to the contact lenses, we have various options of using soft contact lens. I would say it's not indicated in keratoconus, maybe very early cases, or one eye having keratoconus and other eye is normal, then we can use soft contact lenses. Otherwise, routine soft contact lenses don't provide good vision. Kerasoft is a good choice for those patients who do not tolerate RGP at all. Of course, RGP remains the best lens for the treatment of keratoconus. Routine RGP lenses, which has diameter of 9.2 millimeter, or rose scale, which has diameter of 8.8 millimeter. All these lenses, they are smaller than the cornea. They float on the tear film, and initially they do cause some discomfort and some irritation. But over a period of time, it subsides and patient is comfortable. So we can use these lenses comfortably. Piggyback is a system for those patients who are not able to use RGP contact lenses because of irritation. So what we do is we place a soft lens on the cornea, and over that soft lens we use the RGP lens, so that RGP doesn't touch the cornea directly, and the lens is comfortable. Then the patient is able to see. But then you have to manage two lenses, which is not that difficult. Most of the patients are very happy with this kind of management, and we do this kind of management for these patients. But the best lens for moderate to severe keratoconus in my practice is scleral contact lens. Of course, mini scleral contact lens. This is basically provides extreme comfort. It's effective even in advanced keratoconus, and it gives excellent visual quality. And we put fluid and then we use this contact lens. And another advantage that you can use for a very long period or very long hours this contact lens without any significant problem. Intex is another surgical operation which is done to reduce the asymmetry of power of cornea. Now you can see that in this patient picture, lower left, extreme left, we have red area. So if we place the ring here, this steepness will decrease, and also this cone will be shifted towards the center, and the patient's vision will be better. So with this surgical procedure, the quality of vision improves, and the myopic astigmatism can be reduced to some extent. This procedure can be performed in two ways. One is to perform this procedure manually, in which we we make the channel manually. The other is using a femtosecond laser, in which we use the femtosecond laser to make the channel, and then we place the intact ring. Procedure wise, it is quite simple, and efficacy wise, we have to select the cases carefully, and we have to explain the patient its utility in a proper way. Now, topo-guided PRK is another treatment option for keratoconus patients. This treatment is for those patients where the corneal thickness either is less than 500 micron and the number is too high, and we cannot neutralize whole of the number. In this treatment, then what we do is we do the smoothing of the corneal surface, so that patient's quality of vision improves with the glasses. Or if he's using with the contact lenses, again his vision quality improves. What we do is that in this procedure, this is a topo-guided procedure in which we provided the topo map to the software, and the computer put the spots of the laser in such a way that the flattened cornea becomes slightly steeper, and the steeper area of the cornea becomes flat, and in total only 50 micron tissue is ablated. So that way this procedure is safe and can be used in some patients where we want to improve the quality of the vision without going for the total removal of the spectacles. Now, these are the surgical procedures which are required if the disease has advanced significantly, and the procedure is then deep anterior lamellar keratoplasty, in which we do not disturb the Descemet's membrane and endothelium. We remove the other stromal layers, and we replace the other stromal layers with the fresh stroma from the donor cornea. Procedure can be again done with two methods. One is a manual method, in which these days we use big bubble technique, and the other method is femto-assisted DAL, in which femtosecond laser to make the incisions. Penetrating keratoplasty is again a very important surgical procedure for these cases where the keratoconus is already very advanced, or patient has got acute hydrops and it has healed. So that we can rehabilitate these patients, we have to do penetrating keratoplasty, in which we remove the full thickness cornea and we place the full thickness corneal button and we suture it. Again, this procedure can be done by two methods. One is purely manual method, in which we do the manual cutting and then manual suturing. The other method is femto-assisted PKP, in which we make the cuts on the host cornea and the donor button using the laser, femtosecond laser, and then we suture it. So we get early visual rehabilitation if we use the femtosecond laser, but again this adds to the cost of the procedure. So there are new procedures coming on. One is a Bowman layer transplantation, which seems to be effective, but we have to have more studies on this one. And then stromal lenticule transplantation, that you fashion a stromal lenticule and then place it in the stroma so that we can increase the thickness of the cornea, which is already very low in keratoconus. So both these procedures, they need further evaluation, more studies before we can use this procedure for our patients. In the end, I would like to summarize that collagen cross-linking is safe and effective in arresting the progression of keratoconus. Children suffering from keratoconus need early treatment and close monitoring. CXL is possible in thin corneas. Then transepithelial CXL or epi-on CXL is although painless and complication-free, but it's also less effective. So we have to know that. CXL can be combined with PRK, LASIK or SMILE, as we discussed earlier, and those patients who have good corneal thickness, these procedures can be done. So the CXL alone does not improve the vision of the patient, but if the thickness is good, it can be combined with PRK, LASIK or SMILE to improve the vision of the patient and to decrease the dependence on the glasses. Visual rehabilitation with contact lens is safe and economical. However, if the patient has more advanced disease where the contact lens wear is not possible, penetrating keratoplasty or deep anterior lamellar keratoplasty is essential to rehabilitate these patients. Thank you very much for patient here. Any questions, I would be very happy to answer.
Thank you, Dr. Ashok, for a wonderful presentation. And I'm sure this will help the general physicians, the general ophthalmologists, as well as the graduate and postgraduate students who are pursuing ophthalmology. So thanks a lot. And it is now, I think it is clear that this keratoconus is a progressive thinning of the cornea. There is ectasia and the cornea becomes conical. And incidence, as we think, it is quite high actually in Asian population. So world over it is 1 by 1,000, but in Asian population it is much more than that. And the parents should be alarmed if there is a frequent change of glasses. So I think that is important. And we need to arrest the progression and visual rehabilitation. And as high as 20% will need this keratoplasty as an option. So you told about the non-surgical and the surgical options as well, and very clear-cut take-home messages. I'll just repeat that CXL, it is a safe and effective in arresting progression of the keratoconus, and children suffering from keratoconus, they will need early treatment. As CXL is possible even in ultra-thin corneas, and CXL can be combined with PRK, LASIK or SMILE procedures. And visual rehabilitation with contact lenses is safe and economical. So thanks a lot, Dr. Ashok Sharma. I'm sure everyone who will watch this video will benefit. Thank you. Thanks a lot.
Thank you, Dr. Rakesh and Sipher for organizing this and giving me opportunity. Thank you so much.
Thank you.